Hey, my name is Matthew Smith. I teach resuscitation at a large hospital in New York City, and today I'd like to tell you about 3 times when you shouldn't try to fix an abnormal vital sign. We do simulations as part of our training, and one of the things that we consistently see from our providers, really smart, really intelligent people, is that when they see an abnormal vital sign, there is a really strong instinct to try to fix that vital sign, to try to take something that's outside the normal range and draw it back into the normal range with whatever kinds of tools that we have, be it a medication or an electrical therapy. And there's many times when that's the right instinct to have, but then there's other times when it's not. So let's talk about it. First case is a 36-year-old male. He's unresponsive. He has a heart rate of 40. His blood pressure's 210/116, and he's breathing 10 times a minute irregularly. This is a patient where we see people all the time have this instinct to give him atropine and to pace him because they see that low heart rate and they say, gosh, I really need to raise that heart rate. He's unresponsive. He's bradycardic. The problem with that is that you have to think about the cause and effect here. And for bradycardia to be the reason that this patient's unresponsive, the nexus between bradycardia and mental status is blood pressure, right? And so here, his blood pressure isn't low. It's high. For bradycardia to be the reason he's unresponsive, his blood pressure would have to be low. It's not. The hypertension excludes the bradycardia from the list of possible causes for his altered mental status. So then what do? Well, you zoom out and you look and you see that you have 3 findings, a trio of findings, or you might even say a triad of findings. It's Cushing's triad, right? This is a patient with brainstem herniation, and so he's bradycardic, he's hypertensive, and he has irregular respirations. He needs his airway managed, he needs an urgent head CT, and he needs a neurosurgery consult, but what he does not need is to be paced. Okay, next case. It's a 67-year-old female. She's disoriented, and she's in AFib with RVR at a rate of about 170. Her blood pressure is 67/31, and she's breathing 30 times a minute deeply. This is a patient where looking at that heart rate, looking at that blood pressure, looking at the mental status, she's medically unstable, she's hemodynamically unstable, but the question is the reason she's unstable the AFib, or is the reason she's unstable something else, and you have AFib with RVR as a compensatory mechanism? And this is a patient I actually treated many years ago when I was a new paramedic in New York City 911, and just as I was preparing to cardiovert this patient, my carbon monoxide monitor went off, and came to find out that the patient had been experiencing CO poisoning. It had caused widespread vasodilation, and she was in AFib RVR to try to compensate, to try to maintain her blood pressure in the setting of that vasoplegia that was going on. So we got her out of the house. We got her on oxygen. We defended her pressure with some fluids, and ultimately the AFib RVR gradually resolved. Look, there are going to be times when patients are hypotensive because of the AFib, but this wasn't one of them. AFib RVR is tricky to treat because it can be the cause or it can be an effect. Okay, third case. We have a 77-year-old female. She's sedated, and she's intubated for respiratory failure secondary to sepsis. Her end-tidal CO2 is 18. And as people see that end-tidal CO2, they're tempted to say, well, end-tidal to 18, normal value is 35 to 45. Let me bring that back up to a normal value. The problem with that is there's a reason that the end-tidal is 18, and that's because this patient is in a profound metabolic acidosis. And so if you artificially raise her end-tidal CO2 now to 35 to 45, you're knocking out the compensatory mechanism that she has developed for that metabolic acidosis. And unfortunately, what you're going to do is you're going to likely cause her pH to crash and her vital signs to crash shortly after that. So patients with metabolic acidosis, there's a reason they have low end-tidal CO2s, and when we take over their respiratory drive for them after we intubate them, we have to make sure that we maintain that same level of compensation that they've been achieving on their own. Okay, so that was 3 cases where it's the instinct to bring an abnormal vital sign back into the normal range is not necessarily the correct instinct. I hope you enjoyed that. I hope you got something out of it. And if you have any comments or thoughts or questions, I hope you'll share them with me. Thanks. Bye.